James worked 63 hours a week, 2 jobs, 6 days, no benefits at either one. When his appendix ruptured on a Tuesday afternoon, the hospital saved his life in 4 hours. The bill arrived 3 weeks later, $41,000. He made $29,000 a year. This isn't a story about bad luck. It's about math that was designed to fail. Right now, 28 million Americans have no health insurance. Not because they're unemployed. Most of them work. Some work multiple jobs. The confusing part? The United States spends more on healthcare per person than any country on earth. $12,000 per person per year. That's double what Germany spends, triple what the UK spends. So where does all that money go if it's not keeping people covered? The answer involves a system so complicated that even the people inside it can barely explain how it works. But once you see the structure, the failures stop looking like accidents. Let's break it down. Most Americans get health insurance through their employer. Sounds simple, but here's the catch. You only qualify for employer-sponsored insurance if you work full-time. That usually means 30 hours a week or more, depending on the company. James worked 28 hours at a warehouse and 35 at a retail store. Neither employer classified him as full-time. This isn't coincidence, it's strategy. If a company employs 50 or more full-time workers, federal law requires them to offer health insurance. But part-time workers? No requirement. So businesses in low-margin industries like retail, food service, and logistics do the math. Hire 2 part-timers instead of 1 full-timer, pay no benefits, save thousands per employee. James wasn't unlucky, he was profitable. Now, if you don't get insurance through work, you're supposed to buy it yourself on the individual market. The Affordable Care Act created exchanges for this. But here's where the math turns cruel. The average individual health plan costs around $450 a month. For James, making $29,000 a year, that's 18% of his gross income, before rent, before food, before anything. He did the calculation. He couldn't make it work. So what happens when someone like James gets sick? He goes to the emergency room. Hospitals are legally required to stabilize you, regardless of ability to pay. That's the safety net people talk about. But stabilization isn't coverage. They'll fix your appendix. They won't manage your diabetes. They won't catch your cancer early. They'll save your life today and send you a bill that might ruin it tomorrow. That $41,000 bill, it's not imaginary. Appendicitis surgery costs hospitals around $8,000 to perform, but without insurance, you're billed the charge-master rate, an inflated price list that bears no relationship to actual costs. It's like paying sticker price on a car when everyone else negotiated. Insurance companies negotiate these prices down by 60–70%. Individual patients have no leverage, so they pay 5 times more for the same procedure. And here's the twist. When people can't pay, hospitals write it off as charity care or bad debt. Then they raise prices even higher to compensate, which makes insurance premiums go up, which makes more people drop coverage. It's a spiral, and it's remarkably efficient at extracting money while covering fewer people. The common argument goes like this. America has the best health care in the world, the most advanced technology, the top specialists, if you can afford it. That last part does most of the work. Yes, American medical research leads the world. Yes, survival rates for certain cancers are excellent if you're insured and diagnosed early. But nearly 45,000 people die every year from lack of health insurance, according to studies from Harvard and Johns Hopkins. That's 123 people per day. For comparison, that's more than gun homicides and car accidents combined. The system isn't broken, it's just optimized for different outcomes than you think. Insurance companies are profitable. Hospital corporations are profitable. Pharmaceutical companies are very profitable. The inefficiency isn't a bug. For some, it's the product. Here's what makes this strange. Most developed countries treat healthcare like infrastructure. Roads, schools, fire departments. You pay taxes, it's available, costs are controlled. The American model treats it like a market, which works fine for televisions and haircuts. But markets require something specific, the ability to say no, to shop around, to walk away. You can't comparison shop during a heart attack. You can't negotiate when your child has meningitis. There's no supply and demand curve when the alternative is death. So you get a system where an ambulance ride costs $2,000, where insulin that costs $6 to produce sells for $300, where people ration cancer medication or skip surgeries because the debt feels worse than the disease. James eventually set up a payment plan, $200 a month for 17 years. He's 41 now. He'll be 58 when it's paid off, if he doesn't get sick again. The question isn't whether America can afford universal health care. It already spends enough to cover everyone twice over. The question is, who benefits from making sure it doesn't?